You're listening to In the Thick of It, a podcast from the HCM Society, where we interview experts in the hypertrophic cardiomyopathy field to broaden the awareness of new HCM studies and advancements.
Please enjoy today's discussion supported by an unrestricted educational grant from Cytokinetics.
On today's episode, Dr. Anna Wu, a cardiologist with a special interest in hypertrophic cardiomyopathy and echocardiography based at the Toronto General Hospital, welcomes Dr. Sharon Cresci, a cardiologist with a special interest in hypertrophic cardiomyopathy and genetics based at Washington University, for a discussion on HCM and its genetic foundations. Why is genetic testing crucial for identifying familial variants in HCM patients? And does inheriting a pathogenic variant inevitably lead to disease manifestation? Find out on today's episode and discover the importance of lifelong serial screening and an overall collaborative approach in treating HCM. Listen as these experts detail what it's like educating patients and their families about the genetic implications and variability of HCM, and the necessity of vigilance, appropriate follow-up care, and informed decision-making when treating HCM. Let's get in the thick of it. Here's Dr. Wu.
Before we get into the specifics of genetics, do you want to summarize for us your approach to screening family members of patients who have known or suspected hypertrophic cardiomyopathy?
Sure. So once we have one person in the family who is identified as having hypertrophic cardiomyopathy, we follow the guidelines and proceed with testing all first-degree family members. And the recommendations are for performing a screening electrocardiogram or ECG and transthoracic echo. With children and adolescents, we start at that point, and then we continue to screen every year or 2 years until they are into adulthood. So into 21 usually is when we go to. And then we switch over to the recommendations, which for adults are every 3 to 5 years throughout their lifetime until they're in their 50s or 60s. And so one thing we really want to emphasize to our patients is it's not a one and done. You don't get one ECG and echocardiogram and that's clear and then you stop. You have to do the serial screening throughout their lifetime.
And certainly that represents a change from about 2 generations ago. Correct, Sharon, when 30 years ago, when the genetic basis for hypertrophic cardiomyopathy was first defined, a lot of families, a lot of adult first-degree relatives were screened once, and there was less emphasis on serial screening.
Yeah. And I think it's very important because we often do identify family members who do not have the phenotype or the expression on their echocardiogram when we first do the screening, but then later on during serial screening, we identify that they do progress to developing hypertrophic cardiomyopathy.
Thank you, Sharon. I know you're an adult cardiologist, but can you speak a little bit about your different approach to children versus teenagers? That the teenage years obviously are a very challenging time. And what do you say to the adult parents who have teenagers who may need to be screened?
Well, I will get into this, I'm sure, in a minute, but hypertrophic cardiomyopathy is a genetic disorder and it is passed on in an autosomal dominant manner. But it is a disorder that has what we call incomplete penetrance. And so that means that, a family member may not ever develop hypertrophic cardiomyopathy. However, they are at risk of developing it. And so with teenagers, who often are very much into sports and want to participate in sports, it's very important to make sure that they that we identify if they have hypertrophic cardiomyopathy and if their family has risk factors for things such as sudden cardiac death. And so I think that education is always important. We at our center, and I'm sure you at yours, believe very much in a shared decision-making approach to all aspects of hypertrophic cardiomyopathy. And so we just really want to make sure that our parents have full information. And once their children become teenagers, the teenagers can participate in that shared decision-making and also can participate in the discussions and make sure that all of their questions are answered.
That's great. Sharon, if we were to imagine a scenario where, let's say, I'm a patient of yours seeing you for the first time as a first-time consult in your HCM clinic, what would you tell a typical patient who you're seeing for the first time in your clinic about HCM?
Sure. So I typically start and explain that hypertrophic cardiomyopathy is a genetic disorder. As I said, it is passed on in an autosomal dominant manner, which means that 50% of their children have on a probability basis are likely to inherit the risk for the disorder. We know that there are more than 1,500 genetic variants that are causative for the disorder, but we also know that there are some that probably have not yet been identified. And so it's complicated for patients because we are still in the process of finding out more information about this disease. I do discuss that it's inherited in that hypertrophic cardiomyopathy has incomplete penetrance and variable expression. And what that means for a patient is that if their family member inherits the familial genetic variant, they still might go their entire lifetime without developing the disease. And we, at the current time, are unsure what other factors influence whether or not that family member is going to develop the disease. Furthermore, if their family member does inherit the familial variant and does inherit the hypertrophic cardiomyopathy, it may be very different than the hypertrophic cardiomyopathy that they have. And what I mean by that is the degree of ventricular thickness or hypertrophy may be in a different location. It may be greater or less than theirs. If their disease started at age 20, their family member's disease might start at age 15, or it may start at age 30. It's very, very variable. And then the clinical consequences of hypertrophic cardiomyopathy may also be very different, even within one family. And so that's often frustrating, I think, for our patients, because there's no real way of knowing what is going to influence that, or when it's going to show up, or if it's going to show up, or how severe or mild it might be. And so we have a lot of discussion about that and about what the implications of those factors are. And I of course allow for a lot of time for questions and discussion of what this means for that particular family.
That all sounds very important, Sharon, of course, and it sounds like you allow for a lot of dialogue between yourself and the patient and any other family members who may be present. Some of my patients will ask questions like, my dad needed to be on 2 medications. Will I need the same? Or my dad needed to have open heart surgery for his HCM. Will I need it as well down the line? Do you get questions like that as well?
I do. And I think, again, that's kind of what is often very frustrating for patients, because they may say, well, I have a very mild form of the disease. I never developed left ventricular outflow tract obstruction. So I assume that my family members will also have very mild disease if they develop hypertrophic cardiomyopathy. And unfortunately, that's not really true. You can have within the same family, you can have someone with extensive disease, needing a lot of medications, and another family member may never need medications. They may be completely asymptomatic throughout their lifetime.
Sharon, The other question that comes to mind that I get from a number of patients is whether or not HCM and its genetic transmission ever skips a generation. Do you ever get that question?
Yes, I do get that. And the answer is it may seem like it skips a generation because of that incomplete penetrance that we just discussed. So one person who has the familial variant can pass it on to their children, but their children might not develop hypertrophic cardiomyopathy, but then they still can pass on that genetic variant to their children. And so when you look at the family, it seems like it has skipped a generation, but the genetics are continuous. The genetics do not skip, if that makes sense.
Yes, it does. And I think it's just important to spend time explaining it to the patients who ask that question, and especially if they have the family history that you've just described in your example. Moving on to genetic testing itself for HCM, what are some of the reasons for you to recommend genetic testing in the patients who are referred to your clinic?
Sure. There are two main reasons that we would perform genetic testing. The first is if the diagnosis is uncertain, and I'll give you two examples of that. One might be a patient who has hypertension with their echo showing a lot of left ventricular hypertrophy, and you might think that, or you might question as a physician whether that left ventricular hypertrophy is out of proportion to the degree of hypertension that the patient has. And so you might be suspicious that they have something else going on. And because hypertrophic cardiomyopathy is so common, it has a prevalence of 1 in 200 to 1 in 500 people. So it's very common. So you might be thinking that this could be hypertrophic cardiomyopathy, and I'd like to do a genetic test to see if I can identify one of those more than 1,500 genetic variants that cause the disease. Another example of that is if you are thinking that the patient's echocardiogram might be what we call a phenocopy. It might look like hypertrophic cardiomyopathy, but there are some other clinical features that make you suspicious that it's not hypertrophic cardiomyopathy, and instead it's a phenocopy. And this is especially important to diagnose because often there are different treatment options for phenocopies. Such an example of that would be Fabry disease, where enzyme replacement therapy can often limit the progression of the disease. And so you would want to make that diagnosis. And genetic testing, all available genetic testing for hypertrophic cardiomyopathy includes looking for those HCM phenocopies. The second reason that we would perform genetic screening is if you have a family with multiple first-degree family members who are interested in knowing if they have the risk of hypertrophic cardiomyopathy. And so if we can identify the individual with hypertrophic cardiomyopathy, if we can identify in them their causative familial variant, what we would term a pathogenic or likely pathogenic variant, then we can screen all of their first-degree family members and then their first-degree family members in a sort of cascade testing manner to see if they have inherited the familial variant. And then again, we need to make sure that anyone who has inherited the familial variant understands that they're inheriting the risk of developing hypertrophic cardiomyopathy, but they may not ever get hypertrophic cardiomyopathy throughout their lifetime.
Right. Just to follow up on what you were saying earlier about a potential phenocopy, Sharon, what I find fascinating about this field is how much it has evolved in a fairly short period of time. I recall back when I was a medical student to our thinking at that time was Fabry's disease was fairly rare. But in the last several years, many studies have shown that it actually occurs probably at least 1% of the time in HCM clinics, or when you're seeing patients who have unexplained increased LV wall thickness. So I think you had mentioned that there are therapies available. What's interesting is it was an academic point years ago, but now it actually has real world consequences in order to make that diagnosis. Would you say
Yeah.
so?
Yes, absolutely. Those are really good points. Yeah, and it's very, very important. So I think, the message that we really want to stress is if there is any suspicion of hypertrophic cardiomyopathy or a phenocopy, or any family member who's interested in defining whether or not they have a risk, genetic testing really should be pursued. And it is, as you know, a class 2 indication in the current guidelines.
And that's right. And I try to emphasize that with my patients as well. In terms of genetic testing itself, what is the yield of genetic testing, and how do you explain the yield to your average patient?
So the yield, as you know, depends on multiple factors, including the age of diagnosis of hypertrophic cardiomyopathy, the maximal wall thickness, whether or not the person has a family history of hypertrophic cardiomyopathy, whether they have a family history of sudden cardiac death, and then the location and appearance of the hypertrophy all influence the yield of genetic testing. It can be as low as 20 to 40% or as high as 80%. And so in my clinic, I go through the individual's different factors with respect to what I've just described. And then we discuss what their expected yield would be. As we discussed earlier, we try to discuss this in a shared decision-making manner. And many of the patients have a very strong preference. So even if I quote them a low yield, potential yield, they still are very interested in doing genetic testing and seeing if we can identify the familial variant in their family.
And once you have that conversation with the patient and family members, Sharon, walk us through how you would explain to them about what type of sample can be obtained. I know a number of my patients will say they hate the sight of blood, they're very squeamish. So in the year 2024, what options exist for patients?
Yeah, so there are multiple options. Obviously, blood, has been used for many years, but we can also use saliva, a kind of spit kit that many of the patients are familiar with. This is very simple. They have to fill a tube up to a certain line with spit. And the only requirement for that is they not eat with about 30 minutes prior to the test. And then for young children, we can use a buccal swab, and that makes it easier than getting blood or saliva when children are young. Some companies will send test kits to all areas in North America, and that makes it easy for our patients. But it's really a personal preference. And like you say, if someone does not want to have their blood drawn or they don't like the idea of that, there are other options for that.
What about practical issues such as health insurance coverage? Is that a major issue for the patients that you see?
It does not tend to be for the majority of patients that I see. Of course, there are some instances where an insurance company will deny or prefer to have a peer-to-peer, a physician peer-to-peer, where your patient's referring physician will have to get on the phone and discuss the reasons for wanting the test.
Let's say you have discussed genetic testing with the patient, and he or she says, I'm on board, please go ahead. you send off a sample, and then you get the result back. What are the potential scenarios for a result from genetic testing?
Yeah, there are essentially three results, and we do discuss this before the patient, typically before the patient decides whether or not to proceed with genetic testing. So there are really three possible results. One is that a pathogenic or likely pathogenic variant has been identified, and that means that we have identified with a very, very high degree of certainty a causative variant for hypertrophic cardiomyopathy. And what that means for the patient's family members is that they can be screened for this familial variant. If we're doing genetic testing because we were uncertain about the diagnosis, so for example, if they had a lot of left ventricular hypertrophy that we thought was out of proportion to their hypertension, and it comes back with a pathogenic or likely pathogenic variant, then we've made the diagnosis of hypertrophic cardiomyopathy. And we now have another explanation for their left ventricular hypertrophy in addition to their hypertension. So that's one possible result. A second possible result is that it comes back with no pathogenic or likely pathogenic variant identified. Sometimes that's a confusing result because the patient may think that that means that they don't have hypertrophic cardiomyopathy. But in fact, we've made that diagnosis of hypertrophic cardiomyopathy on a clinical basis from our echocardiogram and our EKG and clinical factors. And so what it really indicates is that the sensitivity of the test is not 100%. And so we're just unable to identify the genetic cause in that particular patient. It still can be inherited in a genetic fashion. And so we don't want the patient to think that they do not have hypertrophic cardiomyopathy. What it does mean, however, is that we have to default back to the serial clinical screening that we would in patients who don't undergo genetic testing. So meaning that we need to go back to doing the serial ECGs and echocardiograms every 3 to 5 years in an adult. So the third possible result of genetic testing is identification of what we call a variant of uncertain significance, or VUS. And that is exactly what it says. It's that we have identified a variant, but we don't know if that variant is causative of hypertrophic cardiomyopathy or not. And so at the current time, it's not actionable. We can't screen the patient's family members because we don't know what to do with that information. However, there is the possibility that in the future, this variant would be reclassified into either a pathogenic or likely pathogenic variant, or into a non-pathogenic or not likely non-pathogenic variant. And so we would have to wait for that to be reclassified, if it is reclassified, in order to be actionable. And so similar to not identifying a pathogenic or likely pathogenic variant, we would then have to default back to the clinical scenario where we do clinical serial screening of all family members.
Thank you for summarizing a complicated scenario, Sharon. It's nice to see that our centers have similar approaches. Just along the lines of the group that may have a VUS identified, it's a complicated issue, as you've just outlined. So in my own practice, I also want to have a good conversation with the patient about what that means. And I also tell them that about 10% of the time in the future, the VUS may get reclassified as either a pathogenic variant, as you had just said, or it gets reclassified as not disease causing. And I'm sure you're aware of the study from Australia that showed that that frequency of reclassification occurs about 10% of the time. So I emphasize that to patients, that we need to keep the flow of information between us going, even if the initial result is a VUS.
Yes, I agree. I quote the same percentage as you do. I also tell patients that it is not likely to be reclassified quickly. And at least in my experience, it typically takes about a year or two at least for us to have enough information in the genetics community for that variant to be reclassified. So as you're saying, it's very important to stay in touch and to keep that line of communication open so that we can inform the patients later on if it is reclassified.
Right. And even though it's a complicated issue, I do find that patients are generally very understanding when you explain that the reclassification usually requires more knowledge, more research, more publications, more data. So in my experience, it always takes more than a year before you get back a result that tells you that a VUS has been reclassified, as you've just mentioned. Sometimes it's taken over 3 to 5 years.
Yes.
Yeah. So, but I think patients are very understanding if you explain the process, and if you demonstrate that you're working with them and with the rest of the family to help the entire family.
Yes, I agree. I agree.
As we discussed genetic testing in this patient population, Sharon, are there some additional circumstances or areas that you feel are topical or important to cover?
Well, there is one thing that I don't think we touched on completely, and that is if we have identified the familial variant, the familial pathogenic or likely pathogenic variant in a particular patient with hypertrophic cardiomyopathy, and then we screen their family members, we really need to make sure that the family members understand that if they if they are identified as inheriting that pathogenic or likely pathogenic variant, that does not mean that they have the disease. And so if they do inherit it, then we do proceed with screening, clinical screening of those family members. As we discussed before, we would do a screening EKG and echocardiogram. And then we would, if they don't have any signs of disease, then we would follow up in a serial manner, as we said, if they're an adult, every 3 to 5 years, or if they have the onset of symptoms, obviously you would perform another echocardiogram right at that time. But we also need to make it clear that if they don't have signs of the disease, there are no restrictions. So they are not given the diagnosis, and there are no limitations on sports participation. There are no exercise limitations. They need close follow-up, but until or unless they have some degree of hypertrophy, there is not really any limitation on what they can do. However, even without ever developing hypertrophic cardiomyopathy, they can pass that causative variant on to their children who, as we discussed earlier, may or may not develop mild disease, severe disease, or no disease at all.
Thank you for emphasizing this important subgroup of genetic testing. In my experience, a lot of our younger patients are very reassured at the time we first approach them about genetic testing, knowing that even if they're found to have a positive genetic test, if they're clinically negative, they're essentially carriers, but there are no implications in terms of their ability to participate in physical activities, as you've nicely outlined.
So, as you know, there was a trial that showed that if patients have very small degrees of left ventricular hypertrophy and have inherited the familial genetic variant, that there is a common drug that is known as valsartan that was shown to slow or halt the progression of hypertrophic cardiomyopathy. So I do think that there is some motivation for that patients are very motivated to have this follow-up so that they can at least consider starting on that drug if they have some degree of hypertrophy.
That's a good point, and it speaks to what an interesting time it is for HCM treatment and therapeutics right now. Sharon, you reminded me as we were talking about mild increased wall thickness. Do you want to go over what the criteria for defining HCM is in family members / gene positive patients?
Sure, and that's a really important point. So ordinarily we require a left ventricular wall thickness anywhere in the ventricle of 15 millimeters or greater for the diagnosis of hypertrophic cardiomyopathy. However, if you are a family member of a patient with hypertrophic cardiomyopathy, or if you have inherited the familial variant, so if you carry a pathogenic or likely pathogenic variant, the criteria we use is a wall thickness of greater than 13 millimeters. And so that, as you know, is not very much left ventricular hypertrophy at all. And so it's very important for our physicians to know that and for our patients to know that so that they can get this serial screening and make sure that they know exactly when and if they have developed the diagnosis of hypertrophic cardiomyopathy.
Great. So Sharon, as an experienced HCM clinician, you talked about the role of echocardiography in making the diagnosis in both the index patient and in family members. How do you incorporate the role of CMR in family screening or in following patients serially?
So we do use CMR very frequently. The guidelines very clearly discuss the importance and the how that adds to your diagnosis as well as risk stratification of patients with hypertrophic cardiomyopathy. I also want to say, and I know I'm very biased because I do work at an HCM Center of Excellence, but I do think that when you're talking about just providing full comprehensive care, including advanced echocardiography and advanced imaging, and I would imagine you agree with me on this, but I do think that the centers of excellence really are very passionate about providing this full care, in a consultative manner, and I do think that we are very used to looking for subtle signs of hypertrophic cardiomyopathy. And so I do, recommend that the centers of excellence really be utilized to their fullest in order to provide the optimal patient care.
I couldn't say it better myself, Sharon. And obviously, we've been spending the bulk of our time talking about the genetics and the inheritance of HCM, but it really does speak of how HCM is a very complex condition, correct? It's not just about measurements and some straightforward cardiac symptoms. You really have to bring the entire picture of the entire individual plus their family into the discussion and into the overall management strategy. Do you have any thoughts on that?
I agree completely, and I think that working in conjunction with the referring cardiologist is very important. I think that our patients feel very supportive when they have the HCM physicians collaborating with their own cardiologist, and when they feel that everyone is on the same page and working forward to really acting, in providing them all of the information that they need so that they can make an informed decision.
I think what has also changed with time is how well informed patients are. There are many ways to access information for patients now, and it's much less, shall I say, paternalistic than it was a generation ago. And I think it is good for everyone involved, from the patients, their families, to all of us physicians who spend a lot of our day looking after patients with this condition.
I agree.
Yeah. Any final parting words, Sharon?
No, this has been wonderful. It's been a great conversation, and I thank you so much for taking the time to do this.
Well, thank you, Sharon. It's been a real privilege to have had the opportunity to speak with you and to demystify some of the issues related to a complex issue, which is the genetics and the inheritance of HCM. I'm really looking forward to how this field is going to evolve over the next few years. Thank you so much, Sharon.
Sure, thank you.
That was Dr. Anna Wu and Dr. Sharon Cresci. To learn more about the HCM Society, please visit hcmsociety.org. This episode was edited and produced by Earfluence. Thanks for listening, and we'll talk to you soon on In the Thick of It.